All right. Well, we will go ahead and let people continue to join, but welcome everyone and happy Friday. Thank you so much for joining us and for starting off your morning with us on this beautiful, well, it's beautiful in Maryland, Friday. We just a little bit about the hosting organizations as we get started. I'm also going to go through some quick housekeeping things. Um, Really quickly on the housekeeping end of things, this webinar actually is being recorded. And so we'll be able to share that recording at the end of the event. Additionally, we will have some time at the end of the event for a bit of Q&A. So as questions arise, please feel free to drop those questions to Rock Recovery in the chat. You'll see Rock Recovery as one of the co-hosts. So you can share your questions directly with them and they'll be answered at the end. This is not a CE event, so there are not continuing education credits offered for this event, but we're still really excited that you joined us, and we've got some really, really good content for you. Um, so a quick note about myself and about Rock Recovery. So I am the Director of Partnerships at Rock Recovery. My name is Kristen Soto. And for those of you who don't know Rock Recovery, we are a nonprofit. We're based in Arlington, Virginia, and our mission is to make life-saving eating disorder treatment accessible for all who need it. And so we do this by providing affordable therapy services to teens and adults. We offer in-person sessions in Arlington, Virginia, as well as virtual sessions across DC, Maryland, and Virginia. We know that one of the biggest barriers for people getting access to care is that financial piece. And so as a nonprofit at Rock, we're really, really dedicated to removing that financial barrier. And we do this by taking insurance. We are paneled with Care First, Blue Cross Blue Shield, and Optum UHC. We also offer significant sliding scale to any family who needs it. And so all of the clients who come to us are able to receive that financial support so that they can access care. Additionally, we offer community support groups. We do virtual nationwide peer support groups, faith-based as a way for people who want to integrate faith into the recovery process to be able to do that. And so that helps people break out of that isolation component. And then additionally, we do these community education events with clinicians and other partners in the community. And we're really, really excited to be partnering with Monte Nido and with Autumn, who's just a longtime friend of both Rox and myself. And so thank you, Autumn, for, doing this event with us. And I'll turn it over to you to share a little bit more about Monte Nido.
Thank you so much for the wonderful introduction, friend. It is a pleasure to be here. We love partnering with Rock Recovery, so thank you so much for having us. Just a little bit about Monte Nido. We offer inpatient through IOP levels of care for both adolescents and adults struggling with eating disorders, including virtual services. So our compassionate teams really work to find the root cause of the eating disorder. And at the end of the day, our outcome studies are showing that our clients are getting better and they're staying better. If you have any questions about Monte Nido, I would love to connect. And then with that, I will send it over to Sophia and Victoria. Thank you both so much for putting this together. I'm really excited to learn from you all today.
Awesome. Well, kicking us off today, we're here talking about breaking down ARFID, treating adolescents and young adults.
Great. So a little bit just before we kind of dive in, I want to give you a quick kind of roadmap of where we are headed today. We're going to start by kind of really grounding ourselves into what ARFID actually is, because as many of you know, it is often misunderstood or misdiagnosed, especially when it doesn't present like a classic eating disorder. From there, we'll talk about where ARFID comes from, the etiology behind it, explore how it's really just not just about food. It's more about fear, avoidance, temperament, and sometimes even trauma. We'll look at kind of how all those factors intersect, and we'll also unpack the common comorbidities and risk factor because ARFID rarely shows up alone. Then we'll turn a little bit towards treatment, specifically what's been shown to work, the most evidence-based methods right now in treating ARFID in our clients. And finally, we'll look at the nutritional side of recovery. And my hope today is just everyone will leave not only with more knowledge about ARFID, but also with more confidence in how to show up for these clients in the room. So a little bit about myself and Sophia. I do work out of Rock Recovery. So Kristen and I work well together in that field, and happy to bring myself into this presentation today and talk to you all a little bit more about ARFID. I've been with Rock Recovery now since the beginning of this year, and previously worked out of a residential facility specifically with eating disorders. And now I'm happy to kind of switch back into outpatient with Rock and offer some in-person and virtual sessions in Virginia.
And then my name's Sophia. I'm one of the dietitians at Monte Nido. Right now I'm in the virtual world, so IOP and PHP for adults and adolescents, and the primary dietitian in the ARFID IOP for adolescents.
All right. So when we're talking about ARFID, we're not just talking about a picky eater or someone with low appetite. What we're really looking at is more of a persistent pattern of avoidance or restriction around food that leads to significant physical and emotional consequences. So this could be due to a sensory sensitivity, a fear of something bad happening while eating, like choking or vomiting, or just a general lack of interest in food altogether. But what's really important to highlight, especially in contrast with two disorders like anorexia or bulimia, is that ARFID really isn't driven by concerns about body image or weight. That can throw off a lot of clinicians at first because the behaviors might look really similar. Clients with ARFID will show up with restriction, maybe low body weight or nutritional deficiency, but the underlying motivation is very different. And it's not about how the client with ARFID looks, it's about how eating feels and how unsafe it might seem. So we often see things like weight loss, vitamin deficiencies, dependence on supplements, or major disruptions in daily life, like maybe avoiding meals with friends or not being able to eat at school. And really, that functional interference, that's going to be our clinician's red flag, that we're not just dealing with that picky eater or that picky phase, we're dealing with something that is more diagnosable and deserving of more specialized care.
And then here we have our clinical characteristics for ARFID. We often see the onset of ARFID happening in young childhood, adolescence, or often around a traumatic event and experience. I feel like that's when you notice ARFID coming on in older ages is associated with that traumatic event. And then we have our three subtypes of ARFID. We have the lack of interest subtype, we have the sensory sensitivity subtype, and the fear of aversive consequences subtype. We're going to get into them a little bit more on the next slide. But the clients we see often have limited food variety or limited volume of intake. And this, like Victoria said, is not due to body image concerns, which can result in that significant nutritional, social, and developmental impairments. And we see this more commonly among individuals with anxiety disorders, ASD, or ADHD. And here we have our subtype presentations. First is our sensory avoidance subtype, which is avoidance of food based on that texture, smell, color, or appearance. We have the fear of aversive consequences subtype. So this is the restriction or avoidance of food based on possibly that traumatic event that has happened in the past. It could be choking, it could be vomiting, it could be stomach aches and pains, it could even be allergic reactions. And then our third subtype is that low interest or lack of interest appetite, where we see like that lack of hunger cue, early satiety. Often we hear clients saying things like they often forget to eat, or eating is really a chore for them and they don't find much interest in eating. Clients can present with one of these subtypes, but they can also present with up to all three of the subtypes. So it's really important at the beginning of getting to know your clients, understanding what their subtype is, so we can really understand where to go and how to support them the best. And then we have our etiology of ARFID. So what causes ARFID? A big factor that I always really like to think about is those biological factors here. We can understand that neurodivergence is a huge factor of ARFID. So ARFID is more common in individuals with ASD, ADHD, or sensory processing. We notice clients often having sensory sensitivities, so that heightened sensitivity to textures, taste, smell, and temperatures is often recorded. And then this main factor of this genetic predisposition based on family history, based on maybe them having a previous GI disorder, food allergies, and those taste preferences. We can recognize that, there's also environmental and developmental factors that happen as well that can contribute to having ARFID. So early feeding challenges, such as like difficulty transitioning to solid foods, oral motor delays, these may be diagnosed when a kiddo's very, very young. Maybe when they're transitioning into food for the first time or in those toddler years even. So parents start to recognize these things maybe 2, 3, 4 years old, so very young. Negative food experiences, which can happen at all ages. So, like we've talked about before, choking incidences, vomiting episodes, allergic reactions, or forced feeding events that may happen. Um, and that parental modeling piece. I always think of this as that genetic factor. So maybe parents having ARFID as well. Maybe they don't know they have ARFID, but maybe they are have their own sensory sensitivities. So those foods aren't around the house. So maybe parents are displaying their own food avoidance or anxiety, kind of unintentionally reinforcing that restrictive eating pattern.
Right. And then when we look more at some more etiological factors that cause ARFID, we're dealing with those psychological factors as well, and then that interaction of all these factors together. So when we look at the psychological roots of ARFID, what we often see is layered interaction of anxiety, of temperament, and learned avoidance. So many of these clients, especially those kids and teens, start out with really understandable fears. Like many of these kids will start out with understandable fears around choking or fears around vomiting, or even just being overwhelmed by textures or smells, like things that are pretty common for kids when they are in those early stages of development. And when they do avoid these foods, they feel relief. It's like we avoid something that we're fearful of and we feel relieved. So that relief does end up reinforcing the avoidance. And over time, we get this pretty rigid cycle that is going to look very common or very similar to OCD. And research really backs this up. So we find that in some of the studies that kids with ARFID often have elevated anxiety and obsessive compulsive traits. So we're not just seeing a food issue, we're really seeing a nervous system trying to cope through control and more predictability. And ARFID isn't, also the research states, it's not just about like one thing. It's the result of, again, that temperament, anxiety, and conditioned avoidance all compounding over time. So a kid who's more sensitive or maybe more inhibited by nature may be more vulnerable. And when they experience this discomfort with food, that discomfort starts to generalize. So pretty soon they're not just avoiding one food or one thing, they're avoiding many foods altogether. So if we can help clients gently more re-engage with the foods and experiences that they have come to fear and regulate through that, we can start to interrupt that cycle and rebuild their trust, like more in their body and with eating.
So here we have our comorbidities of ARFID. So for physical health, we can recognize that maybe there has been a weight loss or a lack of developmental weight gain, especially in our adolescents and even our young adults. We can see hormonal changes, stunted growth, and delayed development, meaning they're not hitting their developmental markers that we would expect our teens to. We see low bone density on maybe a DEXA scan, abnormal lab values, and low energy levels.
And for clinicians, it's important to understand that when we are working with these clients with ARFID, it's almost never just ARFID. So this is a population where comorbidities are more of the rule and not the exception. And understanding this kind of full picture is crucial for treatment planning. So anxiety is by far the most common comorbidity, especially specific phobias and generalized anxiety. But we also see a strong overlap with neurodivergence, particularly autism spectrum disorder and ADHD. And these clients will often present with sensory sensitivities, executive functioning challenges, and a need for more of like routine and predictability that can show up in more of like how they approach food. So it's also like not uncommon to see obsessive compulsive traits, maybe more of that rigid thinking, more of that ritualized eating behaviors, And sometimes this can even get misread in treatment as defiance or pickiness when it's really more about control and safety. And then for others, as we've mentioned, those trauma histories or chronic invalidation will really play a role. So we talk about whether it is complex or acute trauma, but also just more of that like history of growing up in a home where it might be more invalidating. All these can really contribute to a comorbidity of like having that trauma history. And some clients may not even identify these experiences as trauma, but their nervous system will tell us otherwise, especially when eating becomes a way to self-protect or avoid those overwhelming sensations. And finally, we'll see depression and mood dysregulation. Sometimes this will emerge as a result of that chronic nutritional insufficiency. So having that kind of depression be secondary as they do engage with more of that restriction and that starvation, but can also be a parallel thread. So especially when eating becomes a source of shame or isolation. And all of this together, whether it be the physical health or the mental health, really just reminds us as clinicians to zoom out. Like ARFID isn't just about someone who will or won't eat. It's about how they've really like learned to survive in a world that might feel unsafe or overstimulating or even just like emotionally overwhelming.
And here we have our risk factors for ARFID. So first, kind of looking at those sensory sensitivities and sensory processing differences. This is one of the most robust predictors of ARFID is this heightened sensitivity. Next, we have those early feeding difficulties, that history of picky eating, those history of oral motor delays or difficulties transitioning from liquids to solids in early infancy and toddlerhood. We may see those struggling with like difficulties bottle feeding, breastfeeding, chewing, swallowing, or tolerating certain textures very early on. Traumatic events or adverse feeding experiences. This would trigger that persistent avoidance. And then the family history and parental modeling. So that family history of anxiety, feeding disorders, GI issues may likely increase potentially having ARFID along with caregiver behaviors such as that over control or maybe their own anxious food patterns or inconsistency in feeding structure. The final kind of piece of this is those temperamental and personality factors. So children with behavioral inhibitions, perfectionism, or difficulty with the novelty or exposures may be prone to developing those rigid or avoidant eating styles.
And then we're moving into maybe some common clinical presentations. So clinically, ARFID shows up in a number of ways that can be really easy to miss if we are only looking for those classic eating disorder red flags like weight or body image concerns. So nutritionally, we see everything, as Sophia mentioned, from like mild vitamin deficiencies to full-on malnutrition. A lot of these clients, especially kids, may not be eating enough volume or variety to meet their basic needs. And for some, that might mean growth stunting or delayed puberty, which can be especially tough to spot if this client's weight is technically on the chart of their growth charts, but trending flat. What's tricky is that weight loss doesn't always look dramatic. Some of these clients hit a plateau instead of a sharp drop, which can make the severity of the restriction less obvious, but no less really impactful when it comes to their overall health and their overall picture of. And socially and emotionally, the impairment is really real. So these kids are missing lunch at school because nothing feels safe to eat, or even talking about young adults, maybe skipping dinners with friends because they're embarrassed or overwhelmed. And that kind of avoidance can really spiral and lead to more of that feelings of shame, more isolation, and more rigidity. It's also really worth noting that most ARFID clients don't have that body image concern again. They're really not trying to be thinner. They're trying to feel safe or in control. And so when we ask about body image and hear more of that, like, I'm fine with how I look, that doesn't necessarily mean that we're in the clear or that like is something that like we need to kind of like take a step back at. Instead, like we are understanding that this distress comes out in other ways. It's coming out in that ritualistic eating habits. It comes out in sticking to maybe only one brand or color of food, or just intense dread leading up to those meal times. And as we assess, it's really essential that we look beyond and ask really like, what is driving this avoidance? What is being protected through this behavior? Because again, it's really not about the food, it's about what that food represents for these clients. So we have a little bit of a case study that we are going to go through, and just we'll have some guided questions throughout. And I know we have quite a large group, so we kind of ask that you send stuff in the chat, or we'll kind of go through it a little bit that way just to kind of rein this in a bit. But we want everyone to be able to kind of participate and learn a little of like how we can apply what we're kind of learning here throughout to some of our cases that we do work with. And so this case study is based on an actual client that I have worked with during my time at a residential facility. So she was 23. She came in underweight with unstable vitals. And despite kind of like how unwell she was physically, she was the one who self-admitted to treatment. So she often said that she felt completely out of control with her eating, but more interestingly, she didn't describe it as restriction, again, for those body image reasons. It was more like food just felt overwhelming or irrelevant. She stated that she really had no appetite most of the day. She skipped meals regularly. And when she did eat, she tended to stick to really highly processed, bland foods. So anything with too much flavor, texture, or unpredictability was like off the table, literally, with this client. She wasn't compensating through exercise or purging, but she did note that she had a goal and a desire to get strong again. So she did have a goal of like wanting to feel better enough to return to the gym and to gain strength. And kind of as we got to know her and her story, what really stood out was her early environment. So, food in her home was really heavily controlled. And if she didn't finish a meal, she'd be punished for it or made to sit at the table until she did comply. And so, that kind of rigid shaming dynamic really shaped her entire relationship with food. In session, this client was really guarded. She didn't make a whole lot of eye contact, and she kept kind of a fidget toy really close that she used often throughout the sessions. She did note kind of in the main milieu within residential, she struggled connecting with other peers, but she did respond really well in session and were able to build rapport and trust really quickly, especially when we started talking about like her specific interests or hobbies. And she really took great pride and enjoyed like really energetically describing them in our sessions. And then that kind of final component that really kind of like nailed this home of like what we might be kind of dealing with when we're coming to treatment with this client was that she reported that things really spiraled after college. So she had this kind of lifetime of, again, picky eating. But when she kind of returned back home to living with parents after college, she lost her social structure and she struggled to find work. And that kind of combination of that isolation, that loss of identity, and that returning to a trigger environment made her eating disorder really kind of tighten its grip. So again, we have a few questions that we can kind of go through if anyone wants to send some of that in the chat. And I don't know if Sophia, if you'd be able to kind of navigate that chat a little bit. But we have a few questions up here to kind of test our knowledge and application to Olivia's case. So based on what we've learned so far, how might everyone think Olivia's presentation fits within the criteria for ARFID? Or maybe like what risk factors from her history really stand out to you as contributors to her current symptoms? And
Olivia also, oh, sorry, Victoria. Olivia had also reported those indifferences towards food and lack of appetite. So how do we differentiate between low interest ARFID subtype and maybe symptoms of depression or trauma response? And what are some things to assess for during those initial sessions? Like Victoria said, if anyone wants to answer in the chat. I'm not seeing anything, so maybe we keep moving, Victoria.
okay,
Cool.
all right. Then we're moving into some psychoeducation strategies. So when we're working with clients with ARFID, especially those who don't necessarily see their eating disorder as or their eating patterns as a problem, psychoeducation as clinician really becomes one of our most powerful tools, not just to inform the client, but to also build trust and motivation in their recovery. So a lot of these clients show up thinking something is wrong with them. and really not understanding that what they're actually doing makes sense in the context of how their brain and nervous system have learned to cope over time. So, one of the first things I do within the sessions is really try and normalize the disorder and frame it as a neurobiological and learned survival response, not a character flaw. So, that shift alone with clients can really open up the door to a whole new kind of therapeutic relationship. We also spend time in psychoeducation exploring the cycle of avoidance. So, as I mentioned kind of earlier, that skipping the scary food provides short term relief, but long term, it actually increases that fear and restriction. So, helping the clients really see this pattern in their own lives often builds insight and lays the groundwork for that exposure work that we're going to do later on and we'll kind of discuss when we move into ERP. So another big piece is really helping these clients connect with their internal cues. So many of our clients have a hard time recognizing hunger, fullness, or anxiety in their bodies. So we can really use those tools like hunger scales and body scans and mindfulness that are going to build that interoceptive awareness and lead those clients to trusting in their bodies again. And of course, we also are going to talk about within psychoeducation, safety and control. So as I mentioned, for so many of these clients, restrictive eating becomes a way to feel safe when everything else is feeling overwhelming or unpredictable. So as clinicians, like rather than challenging that control head on, we really just validate it and then gently start to explore whether the behaviors that once kept them safe are now keeping them more stuck. And finally, that last component, especially with these kids and teens and those young adults, working with families is going to be essential because they're in the home and these are huge, kind of important people within their lives. So, working with families is going to be the most essential tool into getting the recovery more sustainable for them. Oftentimes, because these caregivers are going to, again, see ARFID as defiance or stubbornness, especially when it's presenting in childhood. So, if we give them the language, the tools, and the context to support those exposures without pressure, and really just reminding them that progress in these clients isn't about compliance, it's about that connection. So, as I mentioned, one of the biggest forms of treatment with ARFID is going to be exposure and response prevention. And ERP is really like a very valuable behavioral tool when working with ARFID, especially in those cases where food avoidance is rooted in sensory sensitivities or fear-based reactions. Like, as Sophia mentioned, those past choking incidents, or even kind of some of those clients with really strong gag reflexes. It is going to borrow so ERP with ARFID, it does borrow from the traditional ERP model that we use with anxiety or OCD. But here with ARFID, it's going to be adapted to address specifically those food and eating specific fears. So at its core, ERP is about helping clients gradually face foods or the eating situations they've been avoiding. And we're not doing that all at once and not forcefully as clinicians, but in a more structured, supported, and most importantly, really safe way. So we start first by identifying what's actually being avoided. Is it certain textures of food? Is it certain flavors? Is it the act of eating around others? And then as clinicians, we work to collaboratively build a hierarchy of those feared foods or experiences. From there, we start slow. So once we have this hierarchy, we start slow with maybe a bite, maybe helping the client to smell the food, or having them just sit for a moment at the table, sit for with others around food. The goal isn't to really convince the client to love food. It's to really help their nervous system learn that they can survive that discomfort, that nothing dangerous is going to happen to them, and that they can build distress tolerance step by step. And just as important as the exposure itself is really what happens after, so that response prevention. We help those clients reflect what came up during the exposure. What surprised you? Did your fear match the outcome? And that processing really helps to integrate the experience and builds confidence for the next time. Ultimately, ERP is really going to help these clients rewire their story that they tell themselves around food. So changing it from something that is threatening or overwhelming to more of something that they know now that they can tolerate, that they can engage with, and hopefully the goal is eventually enjoy again. So then we have some types of ERP. And when we're talking about using ERP with clients who have ARFID, it's important to remember that we're not just exposing them to foods, we're exposing them to the experience of eating that has become maybe emotionally or physically dysregulating. And that experience can look really different depending on the client that we're working with. So for some, that focus is going to be on sensory exposures. Those are our clients who struggle with textures, smells, or temperatures. So we might practice tolerating a new mouthfeel or maybe just being near a food that's usually off limits, while other clients might need more of those interoceptive exposures. This is where we're going to help those clients maybe sit with physical sensations that they've come to fear. So interoceptive exposures are going to be more of like exposing them to feelings like fullness, having experiences around nausea, or even anxiety rising in their chest during meals. And then we've got some situational exposures. These are clients who can eat at home, but maybe shut down in a dining room, maybe shut down in restaurants, can't eat around peers or with parents. We're helping them really rebuild safety, not just with food, but with the context around it. And so those are going to be some of those situational exposures. And then finally, in some cases, we do memory-based exposures. And these exposures are going to look more of like revisiting foods that are tied to those aversive events, like choking or being forced to eat. So if a client had a specific experience choking on one type of food, we kind of go through some of those exposures of re-engaging with that food and finding out that like this time we didn't choke. That was kind of like a one-time event, and the chances of it happening are really low. So when makes ERP successful again isn't just pushing someone to finish a food. It is going to be more about helping them stay with the discomfort just a little longer than they could before. And so to do this, we use tools like SUDS, which is that subjective units of distress kind of scaling to track how that anxiety rises and falls in real time. So doing that before the exposure, after the exposure, so that we can kind of gauge where our client is, and we're really validating how hard it is, letting the client know like this is really hard work. We're facing something that we fear, but we're doing that without rescuing the client or without reinforcing that avoidance. And here with ERP, that key is going to be repetition. We're not aiming for perfection or even preference. We're aiming more for this flexibility. The more exposures a client can do in a supportive setting, the more their nervous system can unlearn those fear pathways. And so, like when we pair this work with grounding tools, with mindfulness, and really having that secure attachment within the therapeutic space, it becomes not just tolerable, but it is really transformative for those clients.
Hey, Victoria, if you guys have a second, Caitlin in the chat messaged me a question about a client that she has. And Caitlin, if it's okay, I might have you come off of mute so you can give all the details.
Yeah.
Um,
So yeah, I'm working in outpatient setting. So I'm an outpatient therapist and I'm having a lot of clients who are, you know, young, maybe 8 to 14-ish, and they're coming from being talking about comorbidities. Either they're on the spectrum or they're having ADHD, whatever. The psychiatrist has prescribed them a stimulant. And so that is restricting their food intake throughout the day, especially when they're gone from the home, when they're out at school. They don't have a teacher to be like reminding them to eat. So they're not noticing, they might already have trouble being in tune with their bodies and noticing their hunger. Um, However, being on the stimulant, they actually are not hungry. But then when it wears off, they're coming home and they are just tearing that kitchen up, raiding the fridge. And it's like usually at nighttime when the parents are asleep. So then they're hoarding, they have wrappers under the bed. I mean, I'm seeing this a lot. So it seems to be the parents are wanting to lock the cabinets at night, those sorts of things. And we've we've tried working to get them, their meds adjusted, but it seems to always be the same effect. And I know that we're focused here on like restriction, but I feel like that is part of it. What do you guys, because we're restricting that food throughout the day, right? So then we actually are hungry at nighttime. Like, do you guys have any recommendations?
Yeah. Victoria, do you want me to hop in here from the nutrition side?
Yeah, absolutely.
Yeah. So we see this a lot. Oftentimes with those stimulants, it's really gonna mess up those hunger cues throughout the day. So one thing to think about is like, how do we still get this kiddo's needs met maybe earlier in the day, like making sure they're having a full breakfast before they go to school, before they take those meds. This mean they may need to like wake up earlier as well. And then how do we work with the school too to like find some structured eating times? Can this kiddo go to the nurse to eat some peanut butter crackers? You know, maybe can they bring like an Ensure or something to school with them? This way they're getting some nutrition and energy throughout the day. And how do we set up consistent eating after school as well with the parents? So like coming home, are we almost having like a meal? Like, are you having basically like lunch when you get home and then dinner and then still a full nighttime snack? Really finding that consistency and structure to get that kiddo's needs met because it's extremely important, especially when they're not getting enough food, enough nutrition throughout the school day. So I'm thinking about it from that consistency mindset and like really building those like moments throughout the day.
Yeah, I think this is one of those really tough cases because it seems like this kiddo does have that like inclination of like when the medication you said wears off at night, they're just like ravenous and they're starving, but it's hard to know like have that kind of really in tune relationship with that mind body connection on stimulants. I know it's why so often in eating disorder recovery, we don't kind of prescribe any stimulants to our clients because it does suppress appetite. And that being so hard to manage in terms of recovery and also can really validate the eating disorder on a lot of levels. And so I think as kind of Sophia mentioned, of like, can we lean more into an FBT model with this client, especially given that young age of like having more of that like family lean in for that accountability? Because we're really going to need a lot of structure for this kiddo in terms of kind of treating these behaviors and giving them that nutrition, especially so that things kind of, we don't get to that point of where we are reinforcing these behaviors over time and then kind of spiraling into some more of those other comorbidities, like some of that depression and that anxiety. So it already seems like, yeah, you mentioned they're struggling with more of like being on the spectrum and neurodivergence. And so we kind of want to make sure that we're mitigating all of that before it does kind of spiral out. Is
I
that kind
appreciate
of
that. I do you have any recommendations for I have my own hesitancies against, I understand why they want to, but like locking the cabinets and stuff, I feel like that could just send us in the opposite direction when we get older of like there is shame around this, around the fact that you're hungry. And do you have any recommendations on like how to assist the parents in managing that part of it?
Yeah, I think the biggest part, as you said, is like we're really not trying to stigmatize food or create this unhealthy relationship with food. I think so often parents are like, okay, my kiddo's binging and this isn't kind of helpful either. And so, like, that kind of idea that we're going to do to help is lock the cabinet. So that way they can't binge. But then, like, what are those internal messages that kiddo's now taking away around food? Is this something that, yeah, we now have to hide food or hoard food or continue to kind of develop this relationship where like food has something that I have to earn in some way. And so I think it is more like just giving them still that freedom of access, but seeing how we can pull in structure throughout their day, giving them that more routine access to food. So that way we aren't kind of feeling like we have this buildup of hunger once the medication wears off, but they have that consistent access throughout the day. But I would never kind of give like that kind of psychoeducation to parents of like, we still want this kiddo to have freedom around food. Like that isn't the biggest kind of concern here is that they are binging. It's more of like, let's get them that consistent nutrition throughout the day. We don't want to stigmatize food at all.
Awesome. Thanks, guys.
Mhm. So we are kind of, I don't know, we were a little reticent last time to share anything in the chat, but if anyone would like to this time, we are kind of bringing it back to the case study again with Olivia and noting kind of given what we've been talking about ERP, about some of the psychoeducation, thinking back to this case of this 23-year-old client, if anyone has anything that we want to share in the chat, we have some questions around like maybe like what psychoeducation would be important to provide to Olivia in those early stages of treatment, or even what might be some appropriate exposure targets for Olivia based on her intake presentation. If anyone does have anything that they want to chime in the chat, we love to hear it, and we encourage you to do so.
Hey, Victoria. So I had a question come through to me from a provider that specifically addressed the um, ERP treatment process. And so this provider shared, sorry to throw you guys off the slides, but this provider shared that they're starting to see this more in their practice, especially like with chronic medical conditions, especially GI issues. And so clients are experiencing a lot of pain and discomfort and issues with bowel movements. And the discomfort and pain isn't necessarily getting better with ERP. And so, do you guys have any recommendations to then deal with ongoing discomfort and pain when exposure and response prevention isn't working?
Yeah, I think that's really, really tough one. And I'm glad that you kind of shared that in the chat because it is real hard if like we're now talking not only about kind of like a one-off incident, but something that is actually present in the client's life, like whether it is chronic pain or feeling like that kind of like physical GI upset and like having that actually be reinforced every time this client eats. So exposures are going to be really hard because it's going to be there. That like scary thing is there each time we're doing the exposure. And so like I think first was like how can we give this kind of client more of like support medically? Like are there any ways that we can kind of address this medically first before beginning exposures? I think that would be kind of the first route to take is like is there any medical intervention that we can offer this client to manage some of that GI distress? And then moving into exposure, if we've tried that and really kind of nothing's working, I think it is more of like how can we kind of do from more of like a harm reduction aspect of like how can we just create kind of like a meal plan and safety and stable eating patterns around food. And I'll have Sophia chime in a little bit here too after, but like more stable eating patterns with what the client can manage with the GI distress. So making a meal plan that isn't going to be as activating and having the client re-engage with food that way.
I 100% agree with exactly what Victoria said. I feel like finding that more consistent eating pattern of the preferred foods, of the foods that are safe and maybe not going to cause the GI distress, and then kind of coming back to ERP and exposures when that client's ready. I would also think about like what multidisciplinary team members can we get on board here and really create like a collaborative approach to support that client in the best way possible. Are we working with a dietitian? What does their pediatrician or their PCP have to say? Is there anything medication wise that can support this client? And maybe do we need to work with like a GI team maybe to really figure out if there is something else going on there that needs supported? I've had clients in the past going through, ARFID, either ERP and CBT, and then we end up at a GI specialist and, they're celiac or they're dealing with really bad IBS or different things in that way. So it is really important in that moment to, find out what providers can best support, you as a provider and, the client to get the best like care possible.
Yeah, I think we're just like kind of coming at it from more of like triaging as like we want to get them back to the point where like we're able to face all of these fear foods and be eating more consistently. But this is kind of like one of those approaches where we just have to kind of meet the client where they are because this is going to be actually reinforced and like is a part of like their real life if they're experiencing this every time they eat. And so it's more of like how can we triage and just give them that support? And we'll probably put some of those bigger goals like a reintroducing variety and kind of taking away and like those safe foods with just getting them to have those stabilized eating patterns first and managing that distress. I hope that helps answer the question for whoever that came from. But thank you for bringing that up, Kristen.
Thank you, guys.
Okay, so our next treatment modality we're going to be talking about is CBTAR. So CBTAR stands for Cognitive Behavioral Therapy for ARFID. It's currently our most evidence-based treatment approach for ARFID and is really designed to be individualistic for that client based on subtype, age, developmental needs, and treatment setting. So maybe depending on the level of care that this client is at that you're working with. So the key features of it is that individualized approach targeting specific ARFID drivers, delivered in 20 to 30 sessions depending on severity. And I would say that's mainly for like outpatient is those 20 to 30 sessions. We're integrating a lot of psych education, exposure therapy, cognitive restructuring, and skill-based interventions. We're also involving caregivers when applicable, especially with adolescents and even young adults at times who need that increased support. This isn't a family-based modality, but it is definitely family supported. This is an evidence-based supportive method, like we've talked about. They have used randomized control trials that have shown CBT-AR to significantly increase caloric intake, food variety, reduce stress around eating, often seeing improved quality of life, reduced anxiety, and higher social engagement. Parents and caregivers frequently reported decrease in mealtime conflict as well, and improvement in understanding of ARFID. I think that improved understanding of ARFID is so important, especially for our clients and for their caregivers, their people who are supporting them, their family members, to know that this isn't this client's fault. This is a part of their genetics or their environment, and things have been going on to get us where we are today. So very important there. And this is our structure for CBTAR. So CBTAR is set up into five stages, essentially. Our first one is going to be psychoeducation and rapport building, especially given a lot of education to the family and to the teen, to the client that you're working there to help normalize ARFID, reduce shame, and increase that insight. Step number two is the nutrition and motivation for change step. This is the area where we're really focusing on like what are our goals for treatment right now and how do we prioritize what needs done. A lot of times this is the moment when we're focusing on renourishing, weight stabilization, and maybe weight restoration before we get even into talking about exposures to really make sure that client is ready and their body and their mind is back into a space again where hopefully anxiety is naturally kind of coming down because they're in a more nourished state before we start those exposures. Our next stage here is going to be exposure therapy, which is a core part of CBT-AR. It's structured, repeated exposures to either those fear foods or contents. We have exposures that we'll talk about, I think, on the next slide here for each of the subtypes of ARFID and what those look like. Next stage is that cognitive and emotional processing. So we're addressing the cognitive distortions, we're increasing emotional awareness and flexibility, helping that client to really understand things can shift along the way. And our last stage here is relapse prevention. It's a really big part of CBTAR, I think, especially depending on what level of care the client may be in, to really solidify the gains that they've made, the progress that we've seen, and how we prepare for long-term maintenance. I think really understanding that the root of ARFID at times is like ASD, ADHD, GI disorders, that biologic predisposition. ARFID may never go away, but we can definitely get it into maybe a more manageable space for a lot of clients where they can get back to doing the things that they want to do in life. And if they are at a higher level of care, how do we support them as they step down? Do they need a therapist, a dietitian, a pediatrician, someone that can understand ARFID and support them in the long term? And here are our CBT-AR exposures here. Like I said, these are based on subtype of ARFID, right? So we're going to break them down a little bit. So first we have here is that primary food group building blocks worksheet. Would be for our sensory subtype of ARFID. We're really building this food list, food inventory, of the foods that they're currently eating and the foods maybe that they're willing to learn about. From this list, we're going to create exposures for those food sensitivities and sensory things to really explore food. When we're doing these exposures, we want them to be structured in session, really using objective and neutral languaging. a lot of times people are going to want to be like, well, I love this food. You should love it too. Sorry for the noise if anyone hears that. Um, and we really just want to think about like how we explain the food. Like, wow, that was crunchy. That smell was really sweet. Did you taste the salt? Using that kind of objective, neutral languaging for those sensory exposures is super important. Our middle handout here is going to be our self-monitoring record with hunger and fullness ratings. So this is where we start learning about that interoception. What does fullness feel like? What does hunger feel like? Well, if you're starting to get full after 2 or 3 bites, maybe we need to practice pushing back into that and navigating the discomfort there. So this would be for lack of interest subtype to really help our clients understand what these feelings in their body feel like. And even if you're not interested in eating, where you need to go when you're eating to get your needs met. We also have other interoceptive exposures here that help clients to navigate discomfort. And hopefully, as we do these things, the discomfort kind of comes down. So we have a bloating one, a fullness one, and a nausea one that are all, very interesting to do. I would say these should be done probably in person versus in the virtual world, but it really depends on the comfort of the clinician or dietitian and the client. And then the last worksheet you'll see here is a SUDS scale. So just like in ERP, we use SUDS as well in CBT-AR. So we're creating a 0 to 100 anxiety scale of food, eating moments, eating situations, and hopefully working our way up through them. These are directly from the CBT-AR workbook, but I think a lot of programs, treatment facilities are starting to kind of create their own now, which is pretty awesome. So I feel like, whatever a treatment center is using is what works for them. And I think that's really cool to make it really individual.
So I know we are kind of pressed for time a little bit. And so I think we're going to skip on through some of our case study and kind of try to focus on just finishing out the rest of the presentation. But if anyone, I think, will be sharing kind of this recording later. So using these to kind of like guide some of the learning throughout the way.
Right, so talking about nutrition, stabilization, and monitoring. First, we're going to look at that overall nutritional status of that person that we're going to be working with. This is going to be really dietitian focused of like what we know, right? So we're doing that assessment. I always say we want to identify the key macro and micronutrient deficiencies. So we're thinking big at first. We're thinking carbs, protein, fiber, fluids. How are we doing with the major categories of food? But also thinking small, how are we doing in those micronutrients? The vitamins and minerals listed here are the ones we most commonly see kids and teens and young adults with ARFID being deficient or low in. So really making sure, what does food look like with these things, which kind of pushes into the medical monitoring as well. So understanding that like knowing a client's weight, vitals, labs, that would come into the lab work piece, and that historical allergen testing, super important for understanding where our clients are right now and how to support them best throughout recovery. The really cool thing, a lot of ARFID clients really find data to be interesting, right? And really motivating in the treatment process, understanding that their weight is going up, their vitals are starting to look better, their lab work's starting to look better. So it's really cool to share that information with clients to hopefully motivate them in a way to help them understand that they are moving forward in the process. Um, the fourth kind of piece of this is recognizing the need for potential weight restoration during the renourishment process. We want to review those growth charts, historical data. We want to recognize patterns of height stunting or lack of weight gain. Like if they're on their curve or they've plateaued or they've flattened out, we want to recognize that we need to get them back where they should be moving towards. But even for those who are on their curve, understanding they may need to be at a higher weight to support adequate growth and development. Super important there. And we also want to make sure we're exploring this with the other team members like your pediatrician. All right. And still from the nutrition dietitian side, these are the things we're looking at. to make sure our clients are in a better nutritional state as maybe we're planning exposures, starting exposures. I always think of, renourishment first and then, planning and moving into exposures. So we're finding a consistent eating pattern, mainly with the preferred and safe foods. We're working on time frame management. A lot of clients we see come in, it's taking 2 hours to complete dinner. We want to support them, get it down to maybe a more normalized time frame, 45 minutes, maybe snacks in a smaller time frame. We want to recognize we may need to explore some supplements along the way if Ensure, Boost, things like that would be helpful, or even your basic multivitamins, vitamin C pills, things like that, depending on where lab values are and depending how much, weight restoration renourishment we need and how quickly it may need done to think about those. Um, these are different areas of nutrition education, if you're a dietitian, that are super important to focus on with clients. I want to highlight here the daily needs part and the factors that may increase this. We are working with teens, young adults, adolescents who are in growth period. They may need really high meal plans. They may need to reduce exercise to get their needs met. Things to really think about. I'm rushing through this a little bit here so we have some time for questions. And then the dietitian role and exposures. We want to focus dietitians on planning, being deficiency focused. If the client is deficient in vitamin D, can we start exposures there to get maybe more milk or cheese in their diet? If we're thinking about a safety focused perspective, for allergens, has this adult ever tried peanut butter? Maybe we don't start with peanut butter, and that's where we go to an allergist to try that thing. If another kid in the family has food allergies, things to be aware of, safety focused in that way. And in this way of like mental health anxiety, do they literally feel safe in their bodies doing this thing? And if not, how do we work with a therapist to manage those emotions? And then when we're interacting with that food, we want to be really creative and fun about it. We want the client's buy-in. I always tell parents, most teens aren't going to want to start with like broccoli. If they do, they do, but they may want to start with foods that they notice their friends eating or family members eating, and that may help give them a good motivational start and to build that confidence to move forward. So kind of moving with exposures that support the client and support the client's goals versus our goals. And then completing them in session and then maybe with their support system.
Just to kind of bring it full circle, we'll just quickly go through kind of like the what kind of came about of this case, like working within the residential treatment facility, noting that this was a client who was ultimately diagnosed with ARFID and with autism spectrum disorder, just kind of coming full circle in terms of like what interventions we did nutritionally and clinically to kind of get them into recovery. Now, clinically, when we looked at kind of Olivia's case, you can really see that both ERP and CBT-AR came together to really guide her recovery. So early on, we weren't diving into those big exposures or pushing for full meals right away. We were more building those skills. And so skills for managing anxiety, skills for sitting with those uncomfortable sensations, and navigating the overwhelm that really ultimately made eating feel unsafe. A big focus for Olivia was on interpersonal effectiveness because her eating struggles like really didn't exist in a vacuum. They were shaped by that kind of history of childhood invalidation, that history of being like punished or misunderstood around food. So we worked a lot on like building up advocacy and being able to set boundaries and then eventually being able to advocate for what she needed, whether that was with staff in the facility, with her family, or even with herself. We did spend a significant amount of time just setting up the environment to feel safer. And so that meant a lot of psychoeducation for this client and a lot of psychoeducation for her family. So if this was a client who kind of grew up in this history of abnormal eating patterns in the home and then was going back into the home after college, that meant like bringing the family in for specific meal coaching and really kind of setting up how eating with others didn't have to feel threatening and building that safety within the family environment so that when we are getting ready to step this client down back into that environment, she had some more of those tools. And again, ERP showed up in a lot of like really small but powerful ways. This started with like trying a new brand of food or eating in a room with more people. And even as Sophia mentioned, just kind of sitting with those feelings of fullness after a meal. And so CBT-AR really helped to structure all of that when it came to exposure planning, cognitive reframing, and tying each step back to her long-term goals, like restraining, gaining strength, like going back to the gym, getting stronger, going back to work and feeling just overall more in control of her life. So ultimately, by the time that this client did discharge, she wasn't just eating more, she was kind of like thinking just differently and had a whole new kind of outlook on how we improved her quality of life. And understanding like where her fear foods came from and deciding that she was like really equipped with the tools to keep on building that progress after treatment. So a lot of that honing in on that relapse prevention part of that module 5 of CBT-AR.
And then from the nutrition side, really focused on that structured eating pattern, timeframes for completion, weight restoring. I believe Victoria told me this client was able to restore to 95% of their target treatment weight, which is absolutely wonderful. That reversal of lab abnormalities and the exposures that are completed the whole way through, as Victoria had mentioned, sensory-based cooking, outings, interoceptive awareness, all super important, and they all tie together.
Okay, and I know we're at time, but if anyone did have any questions and want to just kind of stick around, I know Sophia and I are happy to kind of chime in and answer any of those um, right now.
Hey guys, one clinician had a question. Specifically, what's the research on using EMDR for ARFID treatment?
Yeah, I think EMDR can be really helpful. And I think in terms of like specifically if the ARFID is coming from that history of trauma. So if we're having a specific kind of trauma event, I think EMDR can be a really good conjunctive therapy treatment. But we're doing that in conjunction still with that stabilizing of eating patterns. So knowing that like if the trauma is what is the kind of the primary thing that caused ARFID more secondary, we still need to triage from the sense of like this client is going to need more stabilized nutrition. They're going to need to be kind of like cognitively functioning like at the level that they need to. So if they've been really depleted for a really long time based on that history of restriction, like focusing on that first because you're really going to need that like really effective cognitive foundation to do EMDR work. So I'd say like monitoring some of those health concerns first. And then once that is more managed, the stabilized patterns around eating are managed, then incorporating some of that EMDR so we can really get to the root of that trauma that is feeding into the ARFID.
Thanks, guys. I had one last question, and then we do understand if people have to hop off due to time. So thank you everyone for joining. But I think this will be our last question, so I just want to tackle this. And so this clinician said, do you guys have any insight on how to best support folks who may be prone to lower levels of being able to access their interoception or specifically neurodivergent, some neurodivergent clients? And what could be most helpful for them as they're navigating ARFID?
Victoria, do you want to take that one? Do you want me to take it?
Yeah, either way, you can, if you got something first, or I'm happy to chime in after too.
Yeah, totally. So from the nutrition side, starting to connect with that interoception can be really difficult. The thing I always come from is like, how do we find that consistent eating pattern, which is going to jumpstart those hunger cues to get more on track, especially if someone's eating pattern is really off track based on just like how patterns happen, right? So how do we get back on track? Let those cues kind of naturally come up if they can, but also if someone is neurodivergent, maybe doesn't get those cues ever historically, how do we help them to understand their bodies better? And if they're not getting a hunger cue, what are the other cues within their bodies or in their environment can they stick to recognize, hey, it's time to eat? They may not notice they're hungry, but are they noticing they're getting tired? Are they noticing it's really hard to pay attention in class, that their energy levels are dipping down, or they're a little bit prone to more of a trigger or an emotional response versus that logic brain's response? Helping them to understand the other components that could also be hunger could be really helpful.
Yeah, and I think it's really difficult is like first like thinking about like this interoceptive awareness, like it is a skill. So a lot of clients coming in, especially those younger kids, like this are like probably bringing in that bodily awareness isn't something that they really have a whole lot of insight in. And so I think clinically, really starting with like, how do we teach these clients these skills around like bringing in that mindfulness and that mind body connection within session and finding out like how we can meet them there. Like if there are specific ones they're uncomfortable with or have like less insight around like building up to it along the way and giving them that foundation. And I also think with most of our eating disorder clients, they are going to come in and they're going to say that I don't feel hungry or like this isn't just a cue that I have. And like that is true if they have been going through a history of restriction, because so many of them cannot rely on those hunger cues until they do have more stabilized eating patterns. And I know that's something I kind of like bump heads a little bit with my clients on. I'm like, yes, you don't have hunger cues because your body is suppressing them because we're in this survival mode. And so helping them give that education in terms of like this, we do have to have a more consistent pattern around eating, and our body has to rebuild with trust with us first to know it's going to get that nutrition before it's going to turn back online those hunger cues.
Thank you both so much. So that brings us to the end of our time today. Thank you, Victoria and Sophia, for all that wonderful information. It was really, really helpful. We'll be sending out the recording within the next few days, so just keep an eye out on your email for that. And if you have any follow-up questions, you can feel free to reach out to either myself or to Autumn. And with that, I hope everyone has a wonderful Friday and wonderful weekend. Thank you.